Can y'all hear me? I think you can hear me. Yes? Well, so nice to meet you. I'm Arti Thangudu, and I'm so privileged. It is such an honor to be here speaking to all of you. You all in this group have really opened my eyes, and you've enabled me to be the kind of doctor that I want to be, so thank you. And for this conference, I've thought a lot about patient autonomy, and what does that mean? What does that mean to me? And to me, it means giving patients, one, the ability to control their care by enabling them to understand what they actually need, and two, to know their options, and three, to know how to assess the value of those options. So you guys may or may not know this, but physicians suck with money. We are prey to, financial experts offering us awful investments. So it's no surprise that we have no knowledge about the finances of healthcare. And I'm grateful that through the FMMA, I've learned that incredibly important piece. So before I get too far, I'm an endocrinologist. So what the heck is an endocrinologist? Most doctors don't even know what we do. So we are physicians who specialize in the diagnosis and treatment of endocrine diseases, diseases related to the endocrine system. The endocrine system relates to hormones. So diabetes, thyroid disease, pituitary adrenal disease, PCOS, osteoporosis. These are the things that we treat and we have expertise in. And we use a mix of medications and lifestyle interventions to help patients get to their best health. We use tech like insulin pumps, continuous glucose monitoring systems to help people to get to their best hormonal health. And these higher levels of service are beyond the scope of traditional primary care. So let me tell you a little bit about my story. So after my fellowship, I landed my dream job. I was an attending physician in a large private endocrinology practice. I had patients literally flowing into my lap. And after 6 months, I thought I was doing a pretty good job. And soon, I was routinely seeing more than 30 patients in an 8-hour day. The clinic staff could not keep pace, and I could barely keep my head above water because in addition to seeing those 30 patients a day, I was also getting hundreds of messages about patient results, patient phone calls, paperwork to sign because of prior authorizations. And I looked at my partners. They were wrought with burnout, and that confidence, that feeling great, started to turn into fear. And one day, I walked into my exam room, and I saw my young, sweet, compliant type 1 diabetic patient. She's a mom of 2 young girls. She drove from Laredo, Texas to San Antonio, Texas, a 2+ hour drive to see me in my clinic. And she told me that she tried to call my clinic, but she couldn't get through. She literally waited on hold for 2 hours, couldn't get anyone to answer her call. She left messages and couldn't get anyone to call her back. As a caveat, I used to receive messages up to 4 months after they'd been left for patients. So eventually she ran out of her insulin and she was hospitalized for DKA, which is a potentially fatal yet very much preventable complication of type 1 diabetes, and completely senselessly. And I'm gonna cry talking about it, but I felt like I'd been hit by a train. The last visit, we had just been talking about our kids and how to wear an insulin pump with style. And I just felt every bit of her fear and sense of hopelessness in this system that was set up to fail her, set up to fail our patients, set up to fail us as physicians, set up to fail moms. And as a mom of 2 young kids, I shared that fear and sadness. And I knew I wasn't doing a great job. In fact, despite my best efforts, I was sorely failing. And this is not the care we aspire to for our patients. She and I had both lost our autonomy, and we were trapped in a system that set us up to fail. And at home, my own family was struggling. My infant son was failing to thrive due to my demanding work schedule and lack of support. So the traditional healthcare system fails us all. The patients, the physicians, the mothers. It compromises our autonomy. And I knew there had to be a better way. I felt in my core that there had to be a better way, and this did not have to be what it is. And so I learned about direct primary care, and I thought it could translate to endocrinology. And at that time, no endocrinologists were doing direct care at all. Definitely not in Texas, but really not anywhere in the country. But still, I felt like there could be a better way. So a few months after that traumatic patient visit, I built my direct care endocrinology practice. It's called Complete Medicine. And in our clinic, we give patients long visits, direct access and support. They enjoy transparency and pricing. We give them discounts on labs and imaging. We get them scheduled promptly. We answer their calls and questions. We show them the love and respect that they deserve. I think it's been interesting how we've talked about how patients aren't seen as consumers, and I think that's a really good way to put it. But also, as healthcare providers, our patients deserve more. They deserve our compassion and our care in scary situations. And that's truly a privilege that they trust us in those situations. And I feel in my current practice, I can actually give them what they deserve. And Complete Medicine grew faster than I expected it to and continues to serve my patients and gives me to practice in a way that I feel is ethical. But this practice model makes sense. And so a few months after starting Complete Medicine, I was approached by an employer-funded group based out of San Antonio. And this partnership forced me to evaluate the impact of diabetes on employers. They asked me to work with a client who was concerned that diabetes would completely destroy their health plan. They had a 25% diabetes rate, which is actually not that outside of the norm in South Texas. The national diabetes rate is 10%, but in South Texas, we routinely see zip codes with higher rates of diabetes. And diabetes was draining their plan. Their diabetics were poorly controlled, thus incurring large in-hospital expenses. And they needed an endocrinologist, and I was lucky enough that they took a chance on me. So with this group, I have learned the tremendous impact an endocrinologist has on a population and what that impact can do for a self-funded company's healthcare expenses. And since 2020, with the start of COVID, I have been pretty much fully delivering care via telemedicine, which opens up huge opportunities as well. So endocrinology is a unique specialty. We rely on patient history, supporting our patients and labs. There's very little that we glean from a physical exam. And I'll talk about this more in a little bit, but there are not a lot of endocrinologists around. So telemedicine creates this huge opportunity for us to have more access. So how many of you are familiar with a blood test called hemoglobin A1C? Okay, good. So for those of you who don't, or even for those of you who do, hemoglobin A1C is the gold standard for measuring diabetes control. It's not perfect, but it's what we use, and it's pretty darn good. So in diabetes, less than 7% is good control, higher than 8 is bad, and higher than 9 is really, really bad because you are a ticking time bomb for a heart attack, stroke, amputation, or vision loss. So not surprisingly, really high A1Cs lead to complex hospitalizations, surgeries, lots of suffering for the patients, and lots of dollars gone. So let's talk a little bit more about the cost of diabetes. The estimated total cost of diabetes reached $327 billion in 2017. This is data published by the American Diabetes Association, and that was a significant 26% increase over the $245 billion cost estimated in 2012 due to rising hospital costs. So this cost includes $237 billion in direct medical costs and $90 billion in reduced productivity. Both of those costs are very important to employers. So in 2017, People with diagnosed diabetes incurred an average medical expenditure of about $16,752 per year, of which about $9,600 was attributed to just diabetes. And so if we extrapolate that to 2023, which with the rising cost of healthcare, each person with diabetes incurs approximately a $27,500 of expense on medical expenses on average per year. However, we also know that one hospitalization, one heart attack, one amputation, that can take that one person's cost into the hundreds of thousands to the millions. So while averages are important, specifics are important as well. So what were these costs on? In-hospital care, 30%. Prescription medications to treat complications, another 30%. 60% on preventable complications, 60%. Anti-diabetic agents, 15%. Now, mind you, these statistics did come out before Ozempic and Mounjaro, but 15% on anti-diabetic agents and diabetes supplies, and then 13% on physician office visits. So this means that 60% of the cost of diabetes is on preventable complications. So how many people does this even affect? Well, I can promise you it affects every single person in this room, because raise your hand if you know somebody who has diabetes. Yeah, every single person in this room. So more than 1 in 10 Americans have diabetes, but like we said, in certain areas, that number is much higher. About 40% of Americans have prediabetes, so almost half of America is affected by prediabetes. And many people with prediabetes don't even know they have prediabetes, and this is awful. And why do I think that's awful? Well, prediabetes is a huge opportunity. In that traditional healthcare system, we're like, oh, it's just prediabetes. I would like that term, just prediabetes, eliminated from everybody's vocabulary, because there's no such thing as just prediabetes. It is a huge opportunity for us to prevent the terrible complications that come with diabetes and the cost associated with that. Yet in the traditional healthcare model, doctors are borrowing time from their healthier patients so that they can give it to their sicker ones. So prediabetes goes unaddressed until it becomes complicated diabetes. The traditional model of diabetes care is making patients sicker. And why is it making people sicker? Well, because how diabetes care is being delivered in the insurance model is terrible. The system is fragmented. Diabetes is complex. Our patients and physicians lack access to each other and time with each other. Time is needed to care for diabetes well. Time is needed to build a trusting relationship between doctor and patient, and trust makes patients better. 85% of people living with diabetes are being cared for by a primary care provider, and our PCPs are doing the very best job that they can. But they have limited knowledge of diabetes care, and they don't have access to a specialist. And our PCPs need our help. They don't have the time, resources, or expertise that we do as endocrinologists, but they don't have access to us either. So they're doing the best with what they have. There's a 25% national shortage of endocrinologists. Wait time to get into a diabetes expert in the traditional setting is up to 6 months in many places, and 75% of US counties don't even have an endocrinologist. So I want to compare endocrinologists to cardiologists for a second. And I love cardiologists. I'm not trying to say anything bad about them. But if somebody has a family history of coronary artery disease, heart disease, it's pretty likely that they're going to see a cardiologist for prevention. It's not rare for them to see a cardiologist, but if they want to see a cardiologist, they will, and they can. For endocrinology and diabetes, though, we wait until a patient's kidneys are dead and their foot is cut off before we send them to an endocrinologist. At that point, it is too late. We are not magicians. We can't revive dead organs, but there is a very good chance that we could have prevented them from getting there. And, okay, well, why is this? And maybe it's the numbers. There are 25,000 cardiologists for 30 million people with heart disease, all heart disease, while there's about 6,000 endocrinologists in the US for 37 million people with diabetes alone. And diabetes is not the only disease that endocrinologists treat. But more than that, I think it's a lack of awareness. I think that we don't recognize endocrinology as an important piece of care for diabetic patients. We've forgotten that there are experts in diabetes. Diabetes is so common that maybe we've forgotten how important it is. And the issue is that type 2 diabetes is a highly treatable and even essentially reversible disease when it's treated correctly early. But given the lack of experts, patients are referred in late stages after complications have already occurred, and we can't reverse them once they've happened. And remission of diabetes is unlikely at that point. And diabetes distress is really high too, because diabetes is complicated. It's challenging for patients and physicians. Patients blame themselves for their disease, and so does our healthcare system. Our diabetes patients are told they're lazy, move more, eat less. That doesn't work. But that's what our healthcare system tells them. It tells them that it's their fault. And our patients are undersupported, and thus they're getting sicker. And the healthcare system makes it impossible to get the care they need. It's impossible to get a specialist. And moreover, the traditional delivery of care is inconvenient for working people, often requiring patients to take half or full days off. And many people, especially those at highest risk for diabetes and its complications, can't afford to do that. I don't even think I can afford to take a day off to see my doctor, So can you imagine the stress and struggles that most of our patients living with diabetes have? So then they take that half day off, and then they have long wait times due to inundated clinics. And it is impossible for patients to speak to their doctor between visits, even for simple questions. Instead, our outdated insurance-based model with the billing practices that go with it disincentivize use of phone or web communication. There are a lot of issues that we can tackle over the phone, if not all of them, for diabetes, but yet patients are being told that they need to come in and make those inconvenient appointments so we can get paid. So patients leave these short office visits confused, frightened, and with prescriptions they may never fill because, one, they can't afford them, or two, they're too scared to take them. Because imagine, if I was a patient and someone gave me a prescription for insulin after talking to me for 5 minutes, there is no way I would be taking it. So it's a scary medication, the risks are high, and you need to have trust in your provider and access to them to safely take those prescriptions. So why endocrinology? Why am I even here talking to you about endocrinology? And why do I think that patients with diabetes should see endocrinologists? Well, we have a bunch of data to support this. So we have data showing that endocrinology clinics adhere better to American Diabetes Association clinical practice recommendations. I'll tell you something. Before I became an endocrinologist, I didn't even know that there was an entire ADA standard of care guideline for diabetes. And I had pretty good training, and so it's just, in general medicine, there's so many different fields that you're learning that you aren't an expert in a specific one. And so it's not that the doctors are bad, but you only know what you know. And we also have data showing that endocrinology clinics see significantly lower mean hemoglobin A1C levels. Patients seeing endocrinology are more likely to reach goal A1C of less than 7 faster and are more likely to be prescribed better medications for diabetes when compared with primary care. And also, another big piece of the puzzle, there's this big study, the Diabetes Prevention Program called the DPP. Some of you guys may be familiar with it. And that study found that lifestyle was actually superior to medication in reducing progression from prediabetes to diabetes. Lifestyle was actually twice as effective as metformin, which is a medication commonly used in prediabetes. So lifestyle is hugely important, and with that comes that time component that I've talked about a few times. And telemedicine, another piece of the puzzle, has actually been found to have similar or improved outcomes in type 1 and type 2 diabetes, decreased cost, increased convenience, and high patient satisfaction. So these three pieces are things that can revolutionize how diabetes care is delivered. So at Complete Medicine, we bring together endocrinology, lifestyle coaching, and telemedicine to take patients to new levels of health, to save employers money, and to give physicians and patients that relationship that they crave and they need for successful diabetes care. So remember, A1C is the gold standard for measuring diabetes control. A1C dropping is good, A1C rising is bad. A1C dropping means a healthier patient, less likely to go to the hospital, cost savings for the employer. A1C rising means sicker patient, more likely to go to the hospital, very expensive for the employer, and also just bad for the patient. So in our clinical experiment with our employer group that I was so lucky that they took a chance on me to help, even with great primary care, and I will tell you, this is a great primary care clinic. Patients have access, they have support, they have frequent visits, they have long visits with their PCPs, they are good PCPs. A1Cs in this sick population of type 2, mostly type 2 diabetic patients, rose by 0.25%. Despite this great care, they were getting sicker. So with the same exact clinic resources, our telemedicine endocrinology program dropped the same exact patients, the same exact ones. So we're comparing apples to apples, the same exact people. We dropped their A1C by 2%. This correlates with a 50 to 85% reduction in complication risk, which for this particular population led to a potential $11 million in potential cost savings and risk reduction to their employer. I was surprised by the outcomes. In fact, I was just talking to someone about whether they can validate my data again, because I was like, is this even real? But we've reproducibly done this over the past several years. So outcomes were actually slightly better with telemedicine compared with when we were in person. So, you know, those studies that were done that I mentioned before, they were done at the VA hospital, big systems, and they were reproduced in our population. It just tells us convenient, accessible, good care makes patients better. And patients like telemedicine too. So this is an older population, mostly retirees. We thought they would be averse to telemedicine. But every day I have patients telling me, I couldn't even make this appointment if it wasn't via telemedicine. Even older patients have responsibilities. They're taking care of their grandkids. They're taking care of their spouse. They're taking care of a lot of other responsibilities. So telemedicine makes it easier for them. And so we actually studied this too. And we had a 100% satisfaction rate with telemedicine. And this is great news because remember, 75% of US counties don't have an endocrinologist. And telemedicine opens up doors for endocrinology because we can reach those areas. And endocrinology relies on the relationship with the patient. It relies on history, laboratory evaluation. We don't get much from a physical exam. Sometimes, I will admit, I like seeing people in person. I'm here today. I'm not presenting this virtually, right? I like being with people, but that's not practical as far as delivering care to more remote areas, and telemedicine works. And telemedicine partnered with strong primary care is how we can provide better care for our patients, and we're here to support our PCPs. We don't have an adversarial relationship with PCPs. We know that they're doing a great job too, and together we can all be that much better. That's what a specialist is supposed to do. It's supposed to augment the PCP. So you might be wondering, okay, well, what the heck are you guys doing in those clinic visits? Well, how are you getting those results? Well, how do we achieve these outcomes? And to be quite frank, we do it pretty easily. And I'm a little shy to say that, but it's not that hard. When given the time and space to care for the patient, the expertise of an endocrinologist flourishes. And that has been the biggest joy of this journey for me. So we have created a reproducible approach to patients that has worked consistently in hundreds of patients at this point, getting them to goal A1C, getting them off insulin. I get to be that person to say, we're gonna stop your insulin today. That's like the best feeling ever. And I always tell the patients, I think I'm more excited about this than you are. And they're like, no, doctor, I'm more excited than you. And we get into it. I'm like, no, I'm more excited. But anyway, we're all excited about it. So we're getting them to goal A1C, off insulin, engaged, empowered, healthier, and keeping them out of the hospital. So we start with a detailed medical history, and then I do my signature piece, which I'm gonna give away to y'all, but it's a day in the life. It's getting to know that person, getting to know what their sleep looks like. If the sleep is broken, well, how am I gonna fix anything else? I have to know what's broken before I can fix it. We talk about what their exercise patterns look like, what do they eat, what's their work look like, what are the barriers they're facing. And then we go into in-depth education on insulin resistance and the pathophysiology of diabetes. And you guys might be thinking like the patients are totally falling asleep here, what a snooze fest, nobody came, there's a reason we didn't go to medical school, right? But this is actually the aha moment for many of my patients. The patients are just like, oh, you can just see the wheels turning. They start to understand. And I have learned that patients are able to understand complex physiology. They get it. And we just need to take the time to teach them. And this understanding gives them the why for meaningful lifestyle change. And we all know that we need our patients to make that meaningful lifestyle change. Then we discuss methods to decrease insulin resistance. And now they know why they want to exercise, why they want to eat more fruits and veggies, why they want to do those things that we know will make them healthy. Then we talk about how different medications work and the role they can play in insulin resistance and their diabetes. And then we talk about tech and how we can simplify their lives. Diabetes totally sucks, guys. It's with patients 24/7. They have to think about it all the time. And if we can use technology to make their life simpler, it can be completely life-changing for them. And then we come up with a plan specifically designed for that individual in front of us. We always tell the patient that they are the driver of the ship, because they are. They're the ones making the decisions every day. They're the ones deciding whether they're gonna do what we ask them to do. Then we provide easy access between visits. When those patients have those simple questions, they can ask us and we can answer them, and it works very nicely. We follow up closely. It is completely bananas that is Corey in here? No, okay, so I did a second opinion for one of Corey Zavada's patients with Visa Health. The patient had seen a clinician who had inaccurately diagnosed them with type 1 diabetes when they actually had type 2, started the patient on insulin, and asked them to follow up in 1 year. This is a real life scenario that happens all the time. Follow-up in 1 year is like literally the dumbest thing I've ever heard for diabetes, okay? I don't know how to put it in a better way than that. Patients need to be seen at least once every 3 months, at the very least. But if you're making intensive medication changes, asking them to change their lifestyle, they need you to be there to support them often and to be available for questions that come up. And you need to be able to let them ask those questions. So, it's a big deal what we are asking our patients to do. And we can't ask them to do it alone because that's how they got to where they are. Support and education lead to effective patient autonomy. We need to teach them how to fly. So, in addition to direct patient care, we use several innovative approaches to diabetes care to improve patient outcomes and improve access to expert-level care. I'm not gonna be able to see all those 37 million diabetic patients, okay? I'm aware I can't do that, but there are a few ways we can scale ourselves without necessarily seeing every single patient face-to-face. And we have tried to help in those ways too. So one, like I just mentioned, clinician to endocrinologist e-consultations. So these asynchronous consultations enable endocrinologists to get our expertise to areas with no endocrinologist or limited access to endocrinology by removing the barrier of physician state licensing. So for those of you who don't know, physician state licensing is a huge barrier because it's expensive. You have to do all these things to maintain licensure, and if your practice is primarily in one state, it just doesn't make financial or just headache-wise sense to get licensed in all 50 states. It's impractical for doctors. But physician-to-physician e-consultation takes away that barrier of state licensing. And then direct patient education via social media. If you guys don't follow me, I'm on Instagram. My handle is just my name, Dr. Arti Thangudu. But I kind of started this because I noticed that there is so much hormonal misinformation. I promise you there is more hormonal misinformation out there than good information. So I wanted to at least give patients an option to get good information from someone who's actually board certified and an expert in the field. So social media has a broad reach, and we use Instagram mostly, but Facebook and YouTube, and working on LinkedIn. Andrea is going to help me with that, to give physician-created content to patients at no cost. And this has enabled me to reach so many more patients than I could have ever seen in clinical practice in a full lifelong career of endocrinology. So that's a really cool space that we are in. And then primary care provider education. So we want to help empower primary care providers to get better outcomes or to even replicate our outcomes. That would be amazing. And there's no way I'm going to be able to produce 1,500 endocrinologists in the next 1, 2, 3, 15 years. But if we can collaborate and we can help you guys, all the better. So we have a CME course to teach PCPs how we approach patients and how they can perhaps get similar outcomes. So my take-home messages today are: traditional delivery of care makes diabetic patients sicker. Supported patients get healthier. Blaming the patient does not work. We got to get that out of our system. I know that is just pervasive in the diabetes space, but it does not work. And innovation is a win-win-win for employers, patients, and physicians, and teamwork makes the dream work. I truly see all of us working together as a team to get us to the next level in diabetes. So I would love to keep in touch with you guys. This is a bunch of ways that you can contact me. My direct email, that's our clinic website, my Instagram and YouTube, like I mentioned. And, as far as next steps, send me an email, send me a DM, send me a message, and we can chat about how we can work together, what your population's diabetes rates look like, what might be the best solution. I would love to hear from you guys and hear your feedback and what else you guys are looking for in the diabetes space. Any questions? Yes.
Hi, my name is Demetrio. I'm a surgeon. When I ask that question, how do you monetize the doctor-to-doctor consultations?
We just have a flat fee. And we through Visa Health too, they have enabled us, they kind of have that market already, so they send us some consultations and they take care of the billing on that. But we do it by ourselves sometimes, but most of it's through Visa.
Visa Health, you said?
Mm-hmm. And then Corey Zavada is going to be speaking later. She is the CEO of Visa Health. Somebody correct me if I'm wrong. And so maybe she'll be telling you guys more about that platform. You're welcome. Yeah. Oh, of course. It's just my first name, ARTI, at S-A, S as in Sam, A as in Apple, complete.com. Yes.
What are the A1C levels that make you beat that?
Make me what?
Make you have pre-diabetes.
Oh, 5.7 to 6.4.
She says 5.7.
Mm-hmm. And then 6.5 and above is considered diabetes. Any other questions? Okay, well, thank you guys so much for spending this time with me.